just need them for reading, and so I just use an 85 as needed. It's like, okay, here, read this for me. You got your glasses.
When you won't have your emergency ones anymore. Only good for one emergency. Just the one that's waiting for you. Oh, you don't have to. What do you want to do with the minute? Yeah. Could you? For those folks when you're ready to go over everything.
The step stool's right out there.
What's up here?
Steps here.
Okay, thanks. Go ahead.
Somebody would have to lift me up.
should.
Okay.
That's good. Oh, that's always good. Hi, everyone. Today's perpetuating factors again. Who we have coming in?
Leslie just joined.
Leslie, great. One of the great therapists from out in the west part of Chicago, in Naperville region. Any other good people out there?
I just see a lot of hearts.
Hi, hearts. Thanks for the hearts.
Hi, hearts.
Well, we're looking forward to getting everybody really good at Morton's foot, right?
Yes.
Okay, what else is it called? Anybody else? Anybody what else is it called besides Morton's foot?
Orlando just joined.
Orlando, great. Always good to have those people from Orlando.
El Paso.
El Paso, Texas. We like to have them too.
Manchester, California.
Great, great. We got California. Looking good, looking good. So, do you all want to become posture pros?
Yeah.
I do.
Yeah. Okay, so remember these underlying perpetuating factors is what we found was most important in many really chronic pain problems. Like almost everybody who came into the failed surgery clinic had Morton's foot or Rothbart's foot or first metatarsal deficit. Okay, almost everyone coming into the fibromyalgia clinic, we had 20-30 people coming in a day. Almost every single one had Morton's foot or first metatarsal deficit or Rothbart's foot, you know. So many people, it's either short first toe or a long second toe. You could call it different things, but or some people like to call it hyperpronation, you know. So we've got it causes hyperpronation. So we've got all these things that we can correct, and remember that a lot of people, or most, or just about all of the people in really chronic pain almost always have Morton's foot. So let's figure out, we have a few people here today, and we're going to look at everyone's feet, and we're going to look at everyone's hips and everyone's shoulders, and we're going to see where their head is in space, and we're going to look at their ankle and their subtalar joint, and look at where their ankle is, and we're going to see if we can correct everybody to make them, but just correct them just by correcting their feet this time. But no, remember we looked at a lot of other underlying perpetuating factors, but today we're looking at the importance of correcting the feet to help the whole body, and it'll help people with migraine headaches, it'll help people with a rotator cuff injury, it'll help people with reflex sympathetic dystrophy, with people with hip pain, knee pain, shoulder pain, back pain, head pain, neck pain. So it's going to help people with almost many different kinds of pain, and also chronic debilitating pain like fibromyalgia, regional pain syndrome, and things like that. So it's going to help a lot of pain problems. So it's good if we correct this. And who's correcting this in this way? Are the chiropractors doing it? Only the ones I've trained, and a few here and there, part of the Myo Pain Society. Are the PTs doing this? Yeah, some are. The ones that are trained by Trebell and Simons and so forth, but not all of them. Are the massage therapists in the country doing it? Well, just a few that are trained by the people like me and some of the other myofascial trigger point therapists. So there's a few of us out there doing this, but it's so important to correct this in all people. Like, how about if you have a patient coming in and they're on their 6th knee operation, and then you take a look at them, evaluate them, you realize they have first metatarsal deficit, you put the shoe insert in, and it stops them from having the 7th and 8th operation. Wasn't that great?
Yes.
Because they said, well, your operation was good, but you're still in pain, so I'll give you another one, you know. So they was going to give them another one, you know, and because they felt so bad for them, you know, and they wanted to help them, you know, so they were willing to do it again, you know, even though they felt they had done a good job. So this is going to help in physicians with who do operations, and this would, if they corrected this in addition to whatever operation they're doing, then they're likely to have not a failed surgery, you know, because maybe the surgery didn't fail, it's just the person is still in pain, okay? So the surgery might be fine, but the person experiences it as a failed surgery because they still have the pain. So we're going to take a look and find if we have any Morton's foot here in this room. So we're going to give a little background to Morton's foot, Rothbard's foot, first metatarsal deficit. Oh, who could think of one more name for it that I didn't say yet? Who in the audience, in the audience there, out in the world, and knows there's one more name for this syndrome that I didn't mention? Who? Anybody have it in this room?
I could read it.
Oh, go ahead.
Greek toe.
Yes!
What is
Greek toe.
Great toe?
The Greek.
Greek.
Okay,
Greek.
Classic
toe.
Greek
toe.
foot.
Oh,
Really?
Classic Greek foot, because all the Greek statues also have Morton's foot.
Oh.
somebody did say
So we
Greek
can
toe.
pose for
What
a
was that?
They
statue.
did say Greek toe on there.
Oh, they
Greek
said,
toe.
someone
Yeah,
said
Greek
it.
toe.
Someone said Greek toe. Okay, see, people are alert out there. Someone's alert in here. Good. So people have been noticing it, and even on statues going way back. So we see it a lot in cultures that have been wearing shoes. Peoples who don't wear shoes as a culture with a lot of then those people tend not to have Morton's foot. So Native Americans tended not to have Morton's foot because they had been more barefoot walkers, and they could always, when they were tracking, they could always tell it was not a Native American because they would be having Morton's foot, and they would always walk with their toes out. Okay, but if they were a Native American, they would always be walking with their feet straight. And also a few other cultures, but the Chinese, the Japanese, the English, the Europeans, most cultures, the Greeks, all have Morton's foot in about 85-90% of the population. So a goodly amount of people in the population have Morton's foot, which causes fallen arches, and also the two ways that people experience it. So they have Morton's foot. They tend to put their toes out like this, and they tend to stand on one foot and kind of get the cool guy or the cool girl look like this. So you often see them doing this and then that, So they tend to do that. So, and also, so those are a couple of things that they often do. But it also causes a lot of pain and dysfunction because really, you're kind of walking this way instead of this way. And then when you do this, then your arches come up. And so you don't need an arch support because this is like a trainer. When you lift the first toe, all of a sudden the muscles all start coming up. So then you're not inhibiting the muscles, but if you put an arch in, then you're inhibiting the foot from actually creating the arch. So by doing this, you'll see this, we'll see it on different people when we're doing it. We may see that the arch comes up right when we do it. So we'll just see, but over time, so we don't call this an orthotic, we call this a trainer because it trains the foot, and it also brings the floor up to the first toe instead of the first toe having come down to the floor. So because the first toe is off the floor, to get it on the floor, people put their feet out and push in so they could get their toe, which is off the ground, onto the ground. So with the shoe inserts that we do, what they do is they lift the toe, so then you don't bring the floor up to the toe, so that you don't need to turn your feet out to get and go like this to get your toe onto the floor. So that's what we're doing with the correction. And also when you do that, it begins to lift, the muscles begin to train to do their job again. So that's what we're looking to have, So I gave us all a little bit of history here, and I thought we could maybe all together we could read it to our audience a little bit and read it out loud, some little sections we have here. And I'll get did we give that to you? Did we? Okay. That's all right. I'll hand it around.
Okay.
We were just about to print it.
Yes.
Okay. So what happened was this is the beginning of it. Dr. Dudley Morton. Now Morton's foot is not the same as Morton's neuroma. So Morton's neuroma is a different Morton. That's a different Dr. Morton. Yeah, but this is Dr. Dudley Morton discovered significant variations in the shape of foot bones among standard patients in the population. If your second toe appears to be the longest of your toes, or the space between your first and second toe cuts deeper into the foot than does the space between your second and third toe, you may have Morton's foot syndrome. Other indications include bunions, calluses on the ball of the foot, especially behind the second toe. Although the incidence of this condition is high in the general population, among people with chronic myofascial pain, the incidence is very high. So the thing is people who are in pain, they're likely to have this, whereas the general population, it may have it, but people in pain most likely are going to have this, and it'd be good to take a look at it and see if you can correct it. People with Morton's foot syndrome also have an elevated supinated first metatarsal that's elevated and rotated outward. The metatarsals are the bones that extend from the toes into the ball of the foot. So, so Morton, he did this back in the 30s and 40s, and he was a podiatrist. Okay, so he found this to be true, and so he wrote about it, and he had corrections for it. And before we read the next section, I'll share the correction that we used to do for it. Okay, so you guys can take a look over here too. So let's come over here, and I gave you all this here.
Yeah.
This is a copy, but here, and if you bring the camera over here, so here is the correction for the first metatarsal deficit. So what we would do is we take a shoe, like a shoe insert. You guys come over here. You come here. Take a look. So you take a regular kind of shoe insert, you cut off the toes and here, then you put a little lift right here. But he didn't usually, so what we're going to do today is measure how much this should be. And then we will put this in the shoe, and so what we'd be doing is lifting the first toe. Now where you get a lot of the pressure when you don't have this is right here on the second toe, right here. So this is the way we used to do it. But then Dr. Travell, I used to go around with her to a lot of the conventions, and she would go around to every manufacturer of shoe inserts, and she would complain to them that they had an arch support, but they didn't have any first metatarsal support. Mm-hmm. So she created this. I mean, this company created this because Dr. Travell came to them and said, "Why don't you create something like this?" You know, so instead of making something with an arch support with no lift at the big toe, which almost all of them are like that, they created this, a lift at the big toe, and the rest of it's nice and flexible, you see. And the idea is that then all your muscles can work.
See that lift?
Mm-hmm. You can see the lift right there.
Yeah,
so this is 9 millimeters. And many people need 9 millimeters, but many people need 3. Or maybe they need a little less than 3. Or they need 6. You know, so you can work on...
Get a shot of this one.
Yeah, so here's 2 of them. Yes, so, and then this is the thick part is in the center, right here. That's where you put your first toe. Here.
So this is instead of an arch support. So
Correct.
Okay.
Now, you can put in an arch support too, you know, just if you wanted to, you know, just you feel, oh, you got to go with it. I would just do both then, you know, and then see how you liked it with both. Because the thing is this is called the Flying Dutchman's in the 1940s and 50s. Used to call this the Flying Dutchman change in your shoe. Like if you went to a shoemaker, he said, they said, give me the Flying Dutchman. That would be, they would put something under the big toe, but you know, I don't think they knew how to measure it that well, what you needed. But they would lift the first toe. Okay, so but if you look at any arch supports, you'll see that they have everything but the toe lift. Oh, I had a pair here.
Oh, I have orthotics. Do you want some more?
Yeah, yours, and I think I had a pair I took out of someone's shoes a couple days ago. So I'll look around for those, and we'll show them in a few minutes. Yeah.
Could you very much?
Yeah. Do you have a pair like that? Yeah. So sometimes I look at I get both
I
kinds.
have both. I've
Yeah.
got the lift.
Oh, she's doing both. Okay, so she decided to do both.
I have
So
the
this
lift,
would be.
and I have an orthotic.
So orthotics are almost always like this. They're rigid here, and they don't have anything here. But this is the main important ingredient. So they miss the most important thing is having the lift under the big toe. So you wouldn't in many cases you might not need any of this if you had that. Okay,
Right.
so that's what we're going to look at, you know, today. So she put in both. She took this and put it in here.
Yeah,
She
put it on top.
took this and put it on top, which I'll have many people do. So I just said, or they could just go to their person that created these and have them add that to the bottom. You just add that to the bottom of it. You know, just ask them to create this lips 9 millimeters if you had 9 or 6 or 5 or 2, 3, whatever it is. Have them put it right here, and that would correct it. So this is you could go both ways, but you may want to try it without. You could give it a try without and see if it does raise your arches, or does your arch still need to be? Then you could go. You can evaluate it, okay, and decide. Okay, so we want to look for wear on people's shoes. So we want to look for wear on the inside, and we want to look for wear on the outside. So we want to look for uneven wear on the shoe. Now, what happens if there's 2 reactions to having first metatarsal deficit. One is that you walk on the outside of your feet and wear out the outside of your shoe really bad, like really, really bad. And the other is you go like this and you wear the inside out. Okay, so there's 2 reactions to it. And so sometimes we gave it the name. We call these bracers, like they're bracing against it falling in. And then the one that come in like this, we call them relaxers because they just give in. They give into it. And they shuffle along and then wear out the inside of the bottom inside here of their shoe. Okay, so we might look for that. So one thing we look for is, do we have uneven wear on the bottom of the shoe? So here we see we have some uneven wear here, so we have some on the outside right here. So this would indicate someone who's a bracer, someone who resists the falling in and then this walks more on the outside. So we're trying to correct that, but not very bad. Now when I first came in and started, I used to wear my shoes out at about that angle. I was a pretty good bracer. I was just, every shoe had like a complete like that, because I don't wear the shoes. I don't wear any uneven wear on my shoes anymore. But that's like 30 years ago. I used to do that like all the time. I'd always wear out the outside of my shoe constantly. So if anyone does that, you know that they have first metatarsal deficit. Okay, so different kinds of wear that we're looking for. And different kinds of other things we're looking for. We'll take off everyone's shoes and we'll look at their feet. But we're looking for, do they have like a webbed toe between the second and third? Do they have calluses underneath the second toe? Over here where the bunion kind of would be, over there on the big toe over here. So over here on the bunion, over there in the big toe, over here in the center, right underneath the second toe, and over here, those were where your bunions would be, okay? And also you can have a webbed, come here, you see, also you can have a webbed toe between the second and third. So we can measure it a couple different ways. We can put little dots on all the metatarsal heads and see this one is shorter, this one's longer, shorter, 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 like that. And so we could, determine. Then we're also going to look at measuring it with you standing and looking at what the deficit is doing to your whole body. So it's nice to see what it's doing to the feet, but it's also nice to see what it's doing to your ankles, your knees, your hips, your back, your neck, and your head. Okay, so that's one. I would say that's really, really important to look at, because if you're trying to get rid of pain and dysfunction, look at what is happening to the rest of the body. Okay, so let's take a look at people's feet. What do you think?
Great.
Yeah, we'll take a look at our feet.
Let's do it.
Good. Let's look at our feet. Okay, so we're going to read just a little bit more, and then we're going to start taking off our shoes. Okay, I've got a little something for us to read. Who would like to read the next paragraph for us here? Who feels like reading?
I'll read.
Okay, here we go. Okay, so Debbie, let's see. Okay, so if you can start right here.
Okay. With this condition, the big toe, which normally carries most of your weight, is elevated so it carries hardly any weight. For it to reach the ground, the arch must drop and the ankle must roll in. This leads to the condition known as hyperpronation, in which the inside edge of the foot falls inward. People with this condition often walk duck-footed, with their feet splayed outward. Hyperpronation changes how the ankle moves, how the knee travels over the foot, how the thigh bone sits in the hip socket, how the gluteal muscles act on the hip, how the spine is aligned, how the head sits on the spine, and how the jaw or temporomandibular joint functions. All these imbalances can lead to muscular overload, trigger points, nerve compressions, sciatica, piriformis syndrome, and other forms of chronic pain. So even though hyperpronation is a foot and ankle condition, It's often associated with knee, hip, low back, buttocks, upper back, neck, head, and jaw pain.
Amazing.
Okay.
So we're going to just look at one of these pains over here. So take a look. We have a little demonstration here.
Is it possible to get a copy of this information?
Yes, it is possible. Okay, so first of all, we're going to tell you how to, so maybe you could help. So this is an evaluation sheet that's available. You got this off the internet, didn't you? When I said, where was it? You couldn't find it? And then I said, well, go to their website. And where was it?
It was on mortonstow.com.
Mortonstow.com it was. Okay, so you can get this and a lot more information right there, right?
Yes.
So you'll get a lot of the information, but probably it's not exactly the way that I teach it because they're not looking at it exactly the way that I do it. But I love all the materials and everything they do have. But the thing here is they're showing the ankle, how this is, so here how the ankle falls in, okay? How you usually lean over at the waist, your head's forward. Often your knees are bent like that. And then with the correction, you should be straight and the ankle should be straight. Here they're showing in this picture here. So, but it doesn't show the other parts that I'd like to also mention. But we're going to have another evaluation sheet where we look at also the other part. We'll see in a second when it must be right here. But there it is. So we're also going to look at the heights of the shoulders and everything before and after. You know, the heights of the shoulders and hips and everything before and after. So we're adding that to this. So this is theirs. And then this is what I created, but it's not very, it's not great what I created, but we can send it to you. You can have it if you want it. Okay, so this is what they created. I add this to it here. Okay, but I'd like to add it to it, in a different way, but I just do it without just use two separate pieces of paper. So these together. Okay, so let's see. Let's take a look read just a little bit more here. So it's pretty simple to determine whether you have Morton's foot syndrome or not. Just sit down, take your shoes and socks off, and take a look at the space between your first and second toe. Is it deeper than the space between your second and third toe? Does it look like your second toe is longer than your first toe? Note that this isn't always the case, but this is the case most of the time. If you have sufficient knowledge of anatomy, you can also look to see the second metatarsal bone seems longer, or there's some other questions to consider that it may help to make a determination. Okay, so a few other things that we like to look at. And this is like a nice, cute cheat sheet that you can get right off the internet from mortonsfoot.com or mortonstow.com, you said?
Morton's foot, I think.
Oh, it's Morton's Foot. Oh, okay. Okay, all right, it's mortonsfoot.com. Okay, here, so this is a cute little sheet. Did I give it to you?
Yes.
Great, isn't it cute? Don't you like it? Guess there's little pictures. So we're going to take a look this is for the evaluation. You're going to look to see if you have uneven heel wear, even wear in different parts of the shoe. We're going to check right now to see if they have Morton's foot structure. We want to see if they're bent at the waist, leaning forward. We want to see if their knees fall in. We want to see if their ankles are falling in. We want to palpate the subtalar joint and see if it's flat or does it point out. Does it point out? So you want to feel that. We want to look to see if they have a flat foot, and we're going to look at the different wear on their shoes. So those are all really great things to look for, and then we'll look at some more things. We'll read a little bit more. Okay? So we'll get a little bit of history in, and then we'll do a little bit of evaluating. Okay, so let's take a look at our feet, and I guess I'd like to have a marking pen. So I guess we'll show you some marking pen. Great, super. So we're going to take off our shoes. So let's look at some of the shoes. Let's see your shoes. Okay. So take a look at these shoes, and you'll see they don't look like they have too much wear on them there. Oh, yes, they do. So here we go. Okay. Okay, so this would be a bracer. Okay, this is someone who's a bracer. So at first you can just think, So yeah, so then they like to resist the falling in of their foot, you know. So it's nice to correct that. So usually what we do is on this kind of a shoe, we put a little lift right here, and but we only have 3 millimeter lifts to put in this kind of shoe. We glue them right in. Oh, she's going to get it for us. Oh, we're going to correct it. Now usually we don't correct shoes that have this kind of wear on them, because what we're doing is only, it's like
Because there's so much wear already?
yeah, you're supposed to get new ones. Okay,
those are really old shoes.
Oh yeah,
I wear them
okay.
all the time.
Well, but so great that you bought an old shoe in.
Yeah.
Because really, the thing is, then we wouldn't be able to see. You know, if you got a new shoe, we wouldn't be able to
see it.
We wouldn't see what kind of issues we're dealing with. But I'm just saying, I'm going to correct it.
Okay.
But usually, you correct a shoe that's not worn down. It's like.
So is this one more than the other one?
Let's see.
Let's
see.
And I'm asking that because I had a
the right is worse than the left.
Right. I had a botched surgery of I had a bunion that turned into an ape toe.
So it's way off the ground.
It's way off, and it's out that way.
Oh, I didn't look at that yet.
So it's a mess, and I'm so happy. Maybe this can get.
Well, maybe we could do something with that. Yeah. Yes. Okay. So there's this tendency. So
I'm out like this all the time.
Oh, no
all
wonder.
the time.
Okay.
This one not so much.
Remember what you read? You see how that's a reaction to having the big toe off the ground. And look at you got your big toe off the ground.
When I stand, it still
it's
doesn't
always
touch the
off the ground. So what they're saying is that's true of everybody, but it's true of you more. That's what they're saying. It's true of everybody with Morton's foot, but it's true of you more so.
Yeah.
Wow. What a demonstration.
Yay. So I have a really bad bunion on this one. And I have
Okay, all right. Wow, she has so here, this is a little correction.
I need help.
This girl needs help.
I need help.
Okay, so what we're going to do is put 3, so a lot of times, even if someone really needs more than a 3 millimeter correction, in a sandal like this, we often don't put one of the shoe inserts because it would slide all over. So we just have this little correction, and even this little correction can sometimes make a big difference.
Okay, so it's on both.
Someone says the connection is bad. I don't
Okay.
know who
Justin
said
will
it.
look into that, or someone.
Okay. So here's what we're going to do. Everybody, just bear with me. I'm going to restart it, okay, everybody? Yeah, everybody's saying the connection's bad. So.
Oh, no.
Yeah.
no.
Everybody's dropping off like flies. So I'm going to restart it, guys. Just hang on 1 minute. It'll be going again, and I'm going to make sure that we're on a good network. Okay, thanks.